Is it taking?
Maybe 20?
Okay, try again. Yeah.
Okay, so I already showed this slide, so you can see that hepatitis deaths are likely globally to be shooting up in relation to the other major infections. So, you've probably heard about the Global Fund for HIV, TB, and malaria. Well, I wish I was there when they were setting up that organization so they could make it Global Fund for HIV, TB, malaria, and hepatitis. But unfortunately, if we don't do anything, we're going to see increasing problems due to hepatitis. And hepatitis, like many of these infectious diseases, disproportionately affects us in low and middle income countries. So now you might be wondering, I know I already mentioned this, why do we focus so much on hepatitis B? Why is it B? Because there's A, B, C, D, E viruses. Well, this is why. It's really due to the number of deaths. So globally, you can see that out of more than, I think, about 1.3 million deaths per year, 900,000 of them are from hepatitis B. And some of them, you can see in the black and the dark blue, are from acute hepatitis. That's the initial phase. Some of them are from cirrhosis and liver failure. And some of them are from liver cancer, which is called hepatocellular carcinoma. So this stacks up to more than 900,000 deaths a year from hepatitis B. But if I were to make this I can't make this for Zambia. I wish I could. I can't reproduce this just for Zambia because our vital statistics are not strong enough. And we don't have a way to track deaths from hepatitis in Zambia right now. It's something we'd like to do in the future. But if we were, I can already know what would be likely because we don't have much hepatitis C. So this would be very low. E would probably be a little higher, and A would be a little higher. But essentially, it would be even more skewed to hepatitis B. So that's why in Zambia, when we talk about elimination of hepatitis, how are we going to control hepatitis? Most of our effort is on hepatitis B. So I wanted to take you through the timeline because many people, when I start lecturing, they start thinking this is a new disease. Oh, hepatitis B must be a new thing. It's like, we had Zika virus, now we have COVID-19. There's always something new in infectious disease, but this is an old infection. And Ministry of Health has actually been involved in this for many, many years. It's just that, it hasn't reached population awareness, but the ministries have taken many measures already to address hepatitis. So it all started probably in the early 2000s when the blood bank was the first one to start doing widespread testing. So since the early 2000s, everyone coming to donate blood gets a hepatitis. It gets an HIV test, syphilis, Hep B, and Hep C, okay? So right there, the blood bank cut down transmission through blood donors. And by the way, 5% of blood donors are positive. So you can imagine how many people were getting exposed to the virus before this time. Then in 2005, 2006, the EPI program brought hepatitis into the vaccine package. And so all babies born after this time would have gotten vaccine when they were just 6 weeks and over. So this cut down the rate of hepatitis transmission again. Then in 2007, this is when the ART program brought in tenofovir as a first-line preferred drug. And so from that time onward, a lot of people with hepatitis were benefited, even though maybe we didn't know they had hepatitis. So bringing this drug in has really made a difference. And I know that government and PEPFAR and other donors, they don't recognize, there are these spillover effects. So of course they're focusing on controlling the HIV epidemic. There have been so many other side benefits. One side benefit is I'm very sure that this has benefited a lot of people with hepatitis B. Another big action here was Zamfia. So I'm sure many of you know Zamfia. It was a huge community survey, and they're repeating it just now, or maybe they've completed. So in Zamfia 2006, we put a hepatitis B test into the survey. And for the first time, we were able to assess hepatitis B at the population level in adults and children. So that's where, for the first time, we had high quality data. How can you operate in a in a program if we don't have data. So before this time, we didn't actually know what was going on in hepatitis. We didn't have like very good data. Suddenly we did. So we found that 5.6% of adults and 7.1% of adults with HIV, 1.3% of children, 5.9% of children with HIV had hepatitis B, meaning surface antigen positive. So for the first time, we kind of knew how many cases we had in the country. And then finally, starting in 2019, we developed the first hepatitis policy. So this just tells you, it's been a very slow process, but things have been happening. So these are the major historical things you should be aware of. So after Zamfia came out, there was a call to develop a task force. And so Dr. Sankal and I and many other local experts from different fields came together in 2018, 2019, and we looked at the guidelines from other countries, from the World Health Organization, and we looked at our local data, and our research data, and the Zamfia, and we put together our first guidelines, which were launched by Dr. Malama in 2019 at an event in 2019. So, what is hepatitis elimination? So hepatitis elimination is a global strategy that is being spearheaded by the World Health Organization. And the goal is by 2030, so that's about 9 years from now, we would like to cut the new infections and deaths from hepatitis. So we'd like to cut new infections by 90%, and we want to cut deaths by 65%. That's the ultimate goal of elimination. And so here we are in Zambia. Please ignore this column here. 2020 is not very relevant anymore. But these are some targets. So for example, third dose HPV vaccine. This means how many children received all 3 doses of the recommended vaccine. The target is 90% by 2030, and we are reaching about 84% or more according to the EPI program. So that means that 84% of the moms and babies, they go for all of their jabs when they're babies, okay? We know some of them drop out before the 3rd one. So all we need to do is just strengthen the EPI program slightly and we can reach our target of 90%. Now, birth dose vaccine, I'm gonna talk more about this in a second. Birth dose vaccine, we should also be giving it 90% of babies, but we're not giving it at all. So we haven't started. Now, blood donors being screened, we're already meeting the target of 100%. Chronic HPV diagnosed. So how many people in the population are diagnosed with HPV? We think it's less than 5%. So we're hoping to reach 90%. And so we have a long way to go on that indicator. For Hep C, we have no data. And then for treatment coverage, the target is that 80% of people who need treatment are on it. And we're starting off at 29%. Why are we at 29%? Well, the 29% reflects what's happening in the HIV program, what you guys are doing. So you guys, even without knowing a patient's status, you're actually treating a lot of hepatitis B in your facility. So probably we estimated using Zamfia data, that if you try to figure out how many people with hepatitis need treatment, the eligible ones, about 29% of the eligible ones are already getting it through the HIV program. Okay, so again, here's an example where you guys are focused on HIV prevention and treatment. You don't even realize you're also helping us treat hepatitis, and you should be applauded for doing that. You've already brought us from 0 to 29%. And then the next one is HPV incidence, so new cases of HPV. We focus on under 5s. And according to Zamfia, under 5s have a 0.7% prevalence. So this amounts to, I think, about 5,000 children every year being born with hepatitis. And we want to cut that down to 0.1%, just to hundreds of kids. We want to cut it from thousands to hundreds. And then finally, incident new cases of Hep C, we have no data, so we're really not sure where we are. So now let me talk about the different elimination indicators. So let's talk about the birth dose vaccine. So maybe you've heard of this before. So basically, one of the strategies to cut down transmission to small children from 0.7% to 0.1%, where we want to get to, is we need new interventions. We need a way to cut that down. Because what we're doing, we have our EPI program, it's working pretty well. It's reduced it down to 0.7%, which is great, but we need something more. And so the birth dose is basically the concept of giving the baby an extra dose of hepatitis B vaccine right at birth, even before they go home from labor and delivery. And what that vaccine has inside of it is it has the hepatitis B surface antigen protein, and it has an adjuvant to stimulate the immune system. And this helps the baby to fight off the infection if it's been exposed to it. The nice thing is it's very cheap. The vaccine, if it's bought in bulk, can be as low as 1 to 5 kwacha per dose if the government were to invest. And there's also a potential donor because Gavi, the Vaccine Alliance, which is already supporting other vaccines in Zambia, has said that although the vaccine is too cheap for them to buy it, they'll help Zambia and other lower middle income countries with the resources necessary to scale it up from implementation side. Because obviously there's more than just buying the vaccine, there are so many other costs. So the goodness is that we hope that this can be something feasible to use in Zambia in the near future. And unfortunately, I think one example of COVID is sidetracking other agendas, because if it wasn't for COVID, I think even by now we would have really gotten into the planning for this. Okay, so let's talk about a different indicator. So how about raising awareness of status? So this Venn diagram, in orange, this is Hep B monoinfection. Sorry, this is hepatitis B. This is HIV. So first thing to remind you is, from Zamfia, we learned that HIV is more common than HBV, okay? So you can see Zamfia, they found in Zamfia about 980,000 people with HIV, 460,000 with HBV only, and then there was the co-infected. So the co-infected is about 70,000 people, okay? So this is kind of, so you see the overlap. So I'll never tell you that HBV is more important than HIV. HIV is still more important, okay? So, but hepatitis B is there as well. So now out of the HBV mono-infected, about 450,000 people are probably unaware of their status. They're living with the virus, they don't know about it. They might be sick, they might not be sick, most are probably feeling fine. And out of them, we did a community survey in Lusaka province, in urban and rural areas, and we did tested about 5,000 people. And then from those, we tried to find out how many need treatment. And so using that data, we think about out of the 400,000, 120,000 need treatment. So you can see the pool of people we need to put onto tenofovir, to TIA, is not that high, right? So right now within, I don't know, can someone tell me, raise their hand and tell me how many people are on ARVs in Zambia? How many, and just throw out an amount, how many? Joshua. Okay, 1 million plus. So 1 million plus are on ARVs in our facilities. So if we can amplify, if we can be managed to absorb another 120,000, then we can treat all of the people who need treatment for hepatitis B. I'm not saying today, I'm saying by 2030. So that's a very realistic target, right? Because our facilities have so much capacity now that could, in the next 10 years, could they go up to putting another 100,000 onto the same drugs? I believe they probably could. But at present, we don't know about very many people who are on treatment from HBV monoinfection. Like the clients we have with us today from the clinic, you met them, you talked to them, many of them take treatment, but we only have about 100 people at ETH taking treatment right now for hepatitis B monoinfection. And then if you talk to other facilities, there are very few. Each facility has 5. So there might be as few as maybe 200 or 500 people in the country who are being chronically treated for hepatitis B monoinfection, okay? So we have a long way to go on treatment coverage. But for co-infection, this is what it looks like. So the co-infection are the group in the overlap here. So for co-infection, we don't know how many know that they're co-infected. That's one interesting element. So if you're co-infected, you're taking TLD, you're taking Tafid, you're getting your hepatitis treated, whether or not you know you have hepatitis, okay? So we don't really know how many of those are actually diagnosed, but we know that I think in the HIV programs, they're reaching, you guys have hit 90-90, right? 90-90. So that means if you take 90 times 90, you get 81%. So there must be more than 81% that are on treatment. So 81% of these patients are on treatments, and nearly all of them are on tenofovir because I think second line is like 5%. Can anyone tell me how many out of the 1 million, is it 5% on second line or 10%? What is it? Anyone guess? Does anyone know? How many are on first line versus second line out of the 1 million that Joshua mentions? Okay, well, it's a very low number, okay? It should be less than 10%. So almost all of these people with co-infection are on tenofovir, which is good, okay? So the coverage is very high when you think about co-infection, but the coverage is very low when you think about mono-infection. So these are the focus areas for Zambia. And after this, we're going to break you into small groups. I was told that you have 4 small groups already established from the other days. Do you guys remember which group you're in? Okay, so you're going to go back to that same group. And we're going to give you a topic to discuss amongst yourself related to elimination. Just a brainstorm, okay? Because although we're here to train you, we also want to stimulate and gather up your own ideas as to how we can achieve these targets in the next 10 years. So what we're thinking of overall is that we want to focus on the birth dose vaccine because we can cut the new cases down to the target. We want to focus on hepatitis B testing and linkage to care. We want to focus on treatment, optimizing the treatment for co-infection, and then start treating those with mono-infection who are eligible. And then as a hepatitis task force, we also want to close certain data gaps. We don't know enough about mother-to-child transmission. We know from Zamfia that there was 0.7% of under 5, but we don't know exactly which moms are transmitting, and those kind of questions still need to be answered. Hep C, we don't have much data. We only have data on Hep C from the blood bank, and there were several studies from a few HIV clinics. For co-infection, I would love to know what percentage of our co-infected are on tenofovir. Maybe we should be doing more testing in the ART department so that for anyone not on tenofovir, it should be required to get a hepatitis test. Maybe that's the approach. For mono-infection, we need to do to understand who's actually on treatment. Our M&E officer under the program for hepatitis, we went around to facilities, and it was very hard for the facility to keep track of how many people they've diagnosed, how many they've treated. And then finally, we need some data on mortality. Because if we want to show a benefit in terms of mortality, we need to be able to measure mortality. And so that's the end of my lecture on elimination. And so you're going to go back into your small groups for the next 15 to 20 minutes. And Dr. Mildred is going to give each group a topic, and then you read the sheet, you brainstorm on that topic, and come up with at least, you can put it into one PowerPoint slide, or maybe just come up with a very small presentation of 2 to 3 minutes, and then we'll reconvene and we'll ask each group to come back with what they talked about and what their ideas are for elimination of that one specific target. Back to you, Mildred. Just tell us about the facts of your elimination target and your assignment, and then this is what you came up with. We'll give you about 5 minutes, and then we'll have a little Q&A for us. Thank you, Dr. Allen.
Okay. Good afternoon, everyone. As I've been introduced, my name is Dr. Ronald Simsofe. I'm representing Group 2, and for us, the discussion or the indicator was on, apologies, we couldn't put it on the slide, but the discussion was on hepatitis B treatment, and the fact or the discussion is that by 2030, the global target is that 80% of people with hepatitis B and who are eligible should be on antiviral treatment. And the assignment was to brainstorm on ways we could understand how many people with hepatitis B are on therapy at our facility and how we can measure this indicator. So the first thing we thought of was to find ways. Okay, thank you. So the first thing we looked at was, I think as it has been highlighted from the discussion so far, we have clients who are on treatment, but the issue is to know how and where they are on treatment. So the first thing we looked at was understanding how or understanding the number of people who are on therapy. And in this case, we needed to find data sources which we can use to identify those clients. And of note, we looked at one, we need the hepatitis B screening tool. Okay, we need an hepatitis B screening tool in both ART and the general population. ART, we need to know, I think from the presentation it was highlighted that people are on treatment, but we don't know how many. So that will help us to capture that data. Then secondly, we need the testing register. This will just be for hepatitis B, such that when we know that the way we do for HIV, I think it helps us to identify who was tested and the result. Then those who test positive, they will need to be screened according to the criteria that has been provided, such that if they are eligible using that criteria, they will be put in the treatment register. And we find that we'll be able to capture the information from the treatment register of what we are looking for. Then the other part is the contact tracing register. Considering the fact that this is mostly familial and all, there is need to contact trace all the index from the person who was tested positive. So that's for just the general population. Then specifically for pregnant and breastfeeding monitoring, we need to have also a mother-baby pair register so that we can do cohort monitoring for those babies that are born from hepatitis B positive mothers. And then there's also need to include hepatitis B in the health management information systems, so that even that data is kept and it can be generated so that we have a wide picture, which can also include mortality and morbidity from hepatitis B. Then in terms of process indicators, what we came up as a team is we need to determine the positivity rate. So from these registers, if you look at the testing register, it can give us, when you look at the total number of people who are positive, and versus the total tested times 100, it will give us that positivity register. Then on treatment register, we need to look at the total number of people on treatment, and this is with the eligibility criteria in mind. And then we'll compare that to the total number of positives which we have at facility level times 100, and that will help us to identify the treatment rate. That's the end. Thank you so much.
Thank you very much, Group 2. We have time for just one or two questions or clarifications from the audience. That's fine. So we actually had a small communication breakdown, and so we're going to break for lunch earlier than expected, and then we'll come back half an hour earlier because of the way they're doing lunch here. So I think we're going to break for lunch now for the next hour, and before we go, make sure every group is given their presentation to chat. When we come back, we will start with the rest of the group presentations. Thank you all for your attendance and your alertness this morning. Don't read too much SEMA, okay? I don't want anyone going after. Of course, it's hepatitis, so no alcohol, please.
Yes.